can get started. Everyone will join us as we go on with the conversation. So welcome everyone. Thank you so much for joining us today for the next session in Global Health Course Shift Happen series, where we'll be talking about vaccine apartheid, the inequity in the COVID-19 vaccine supply and distribution. I am Anita Namuyaba, GHC's Community Impact Manager for Eastern Africa, and I am delighted to be here with our exceptional panelists and moderator. So at a moment in our world's history where we can begin to see an end to the havoc of the COVID-19 virus spread due to the availability of vaccines, there is limited access of these vaccines to low-income countries. This possesses a global challenge in our ability to control the pandemic. Our panelists today each bring a wealth of professional experience working in COVID-19 response and vaccine supply and distribution. I'm therefore so grateful to each of them for taking the time to be with us today and to share on this topic. I'm also thankful to each of you for joining this conversation. It's my honor to introduce our moderator today, Mwelwa Chasaya. Mwelwa is a GHC alum from the 2020-2021 Zambia class. She is an ardent advocate for HIV prevention in adolescents and a public health analyst with a biomedical science background. Mwelwa has worked in both government and the NGO sector with a wide range number of responsibilities that include biomedical scientist, quality officer, and public health analyst. She received the Ndola Teaching Hospital 2018 Award for Most Innovative Head of Section. Over the past year, Mwelwa has worked on several COVID-19 response initiatives, most notably the coordination of Zambia's Ministry of Health partners and stakeholders during the COVID-19 incident management system meetings. She also contributed to the formulation and distribution of COVID-19 information education and communication, where she worked with the health promotion unit at the Ministry of Health. Furthermore, she conducted quantitative vaccine data analysis resulting in the formulation of infographics and also formulated frequently asked questions that addressed infodemics around the COVID-19 vaccines. Mwelwa will be introducing our panelists for today's discussion on the causes of the disparities in the COVID-19 vaccine supply and distribution between high-income and low-income countries, the strides being taken or that should be taken to address these gaps, and how to prevent the recurrence of these inequities in the future. I hope everyone on this line will also share your insights, comments, and questions in the chat and Q&A box. We hope to get as many of them as possible. Mwelwa, Jacqueline, Fred, and Thembi, thank you again for joining us. Mwelwa, I will pass it to you to introduce yourself and our panelists today. Over to you, Mwelwa.
So thank you very much, Anita. So as Anita has mentioned, my name is Mwelwa Chasaya, and I'm pleased to introduce our three panelists today. So joining us are Jacqueline. So Jacqueline Anena is a public health specialist and a senior program officer for vaccines and immunization at PATH. Okay, so she leads efforts to improve immunization coverage and vaccine supply chain. She provided technical support in planning for COVID-19 vaccine introduction, development of the vaccine's deployment plan, and continuous planning and supervision of COVID-19 vaccination. She previously supported the Uganda Ministry of Health in development of HPV coverage improvement strategy through program coordination, training of health workers and
I think we lost Mwelwa. I will just proceed with the introductions and then she can join us when she's able to reconnect. So as she was still introducing Jacqueline, she previously supported Uganda Ministry of Health in development of the HPV coverage improvement strategy through program coordination, training of health workers and teachers, supervision of coverage improvement activities in both rural and urban areas. She is also a recognized immunization program expert, citing on key technical advisory forums, including the EPI Technical Committee and Vaccine Supply Chain Management Committee. Jacqueline holds a master's degree in public health and has over 8 years experience in implementing maternal, newborn and child health programs in the nonprofit sector. She was previously a Global Health Co-Fellow at the Foundation for Community Development and Empowerment. And before that, she worked with World Vision and Malaria Consortium in Uganda. Thank you, Jacqueline, for being here. We also have Fred Luwaga. Fred is a statistician and currently working with the Clinton Health Access Initiative for the past 3 years as the Uganda Vaccines Program Manager, where he's been leading efforts on supporting the expanded program on immunization response to the COVID-19 pandemic through vaccination and sustained gain traction in routine immunization for children amidst this disruptive pandemic. Together with a team of 8 program staff, Fred provided technical support to the EPI national team, the National Medical Stores and National Drug Authority on vaccine deployment, monitoring and evaluation. He sits on several committees that include the National Planning and Coordination Committee for COVID, the Technical Coordination Committee for Routine Immunization, and the EPI Monitoring and Evaluation Technical Working Group. He has over 10 years working experience in the public health sector. His earlier years were spent in varied health programs, doing monitoring and evaluation, while the recent ones have been spent managing health programs, specifically the vaccine program for Chai Uganda. Fred previously worked with Baylor Uganda, spanning several roles that included monitoring and evaluation, coordinator and data manager for HIV/AIDS pandemic control. And through his work, he has co-authored several publications on success interventions, specifically around maternal and child health. Thank you so much, Fred, for being here with us. Lastly, on our panel, we have Thembi. Thembi is a public health physician who uses her passion for clinical medicine, public health and advocacy to advance health delivery and to enhance resilience to infectious diseases. She's particularly interested in reducing inequities in sexual and reproductive health and rights among women and the youth. At present, she's a medical epidemiologist at the CDC Foundation and leads the District of Columbia's COVID-19 emergency response for healthcare facilities. Thembi earned a medical degree from the University of Malawi and a master's degree in public health from Washington University in St. Louis. She also completed a Global Health Co-Fellowship with New York City's Health Department in the Bureau of Sexually Transmitted Infections. Prior to this, Thembi worked as a physician in Malawi and volunteered with the community organizations providing youth-oriented health services in Malawi. Thank you so much, Thembi, for being here with us. So I would like to go in to each of you, to give time to each of you to share more bits about your work on vaccine supply and distribution. Please also tell us more about the gaps you have witnessed in your work that are existing in the COVID-19 vaccine accessibility. Let's start with you, Fred.
All right, thank you, Anita. I'm honored and pleased to be with this team in this discussion. Good afternoon, good morning, good evening, everyone who is who has joined in on this webinar. My submission will mainly be from a perspective of someone working within a low-income country. I have actively been supporting the EPA program plan for vaccine deployment, specifically this COVID-19 vaccine. And this planning entails identifying the priority groups which if vaccinated, we would realize the benefits of the public health benefits of controlling this pandemic in terms of reducing severe disease and fatal outcomes, specifically deaths. It also entails planning on vaccine delivery models, supply chain distribution systems, and as well as management of reverse logistics. So the gist of our discussion today, I think, is mainly around the supply chains, the procurement and distribution of vaccines, or mainly around access of vaccines. So Uganda's plan is to vaccinate all its population above 18 years. And this is about 21.9 million, which has also been phased. So of that 21.9 million, there is a core priority group, which is about 4.8 million. And so the struggle has been on to access vaccines for this top priority group since the last quarter of last year, 2020. But we never got a breakthrough until March 5th this year, 2021, when we managed to receive over 900,000 doses, having fulfilled all the COVAX facility requirements around mid-Jan. So this consignment came in through the COVAX facility arrangement, but as you can imagine, it was also still a drop in the ocean for the topmost priority population of about 4.7 million people. The country had, in the initial phases, also identified some resources and tried to have bilateral engagements with the Serum Institute of India to secure some doses bilaterally alongside the COVAX facility. Yeah, but this fell through mainly because of the issues that happened in India, mainly upsurge of the pandemic, that side of the world, and the production there was reprioritized to cover that their country. So the country has had to continue relying mainly on tranches coming in from the COVAX facility, as well as a few donations. We have some donations from government of China, and recently we also received some donations from the US for the Moderna vaccine. So overall, we've just slightly received, we've received slightly over 2 million doses, which is basically just covering about 5% or under that of the prioritized population. This difficulty in accessing doses and also getting them in tranches and bits has made deployment also a tall order, because you start and stop. So there is gained momentum. Then you have to hold because you've run out of the doses that were received within that consignment, and then have to wait on another tranche coming in, as you still look out for bilateral agreements, which have not been so easy to come by, as we will discuss going forward. Let me pause here for now.
Okay, thank you very much, Fred, for those highlights. It's really good to see that all this effort is being made, especially in terms of prioritizing the priority populations, as well as looking at that inadequacy in the number of doses that are coming in. I think I can also allude to that. It's very much similar in Zambia as well. We've had this priority population coming in, and the challenge is getting the adequate doses that are going to suffice for that number, for that population in particular. So over to you, Thembi. So yeah, are you able to just share a little bit more about your work?
Yes. Hi, everyone. Good morning, good afternoon, and good evening to our audience. So essentially, I am a medical epidemiologist with the District of Columbia, which is Washington, D.C. in the US. And it's a different setting from everyone else's, as they've shared, but at the same time, I also am in a unique position because I'm still involved with my with the community I grew up in Malawi. So essentially, I'm straddling two worlds that are very, very different in relation to how the impact COVID has had, and in relation to vaccine distributions, and in relation to recovering from the pandemic as a whole, and how the healthcare systems have been able to handle it. What I do each day is essentially we try to ensure that the healthcare facilities or healthcare space are safe for patients or visitors, as well as the healthcare workers providing the care. So that involves creating disease management systems where we monitor everything from actual COVID cases, as well as where we also monitor things like vaccinations, recoveries, deaths, hospitalizations. So I'm more of the on the front line, what is happening, and we see the impact that the vaccinations have with our clientele. So I work with both publicly funded institutions as well as privately funded institutions in the region, and work with everything from hospitals, private clinics, and nursing homes. And so I think I may just be able to share a different perspective, since the numbers that you've mentioned seem a far cry from what is happening here. I think as of yesterday, we had over 210 million Americans who had received their first dose of the vaccine, and actually over 1.6 or 1.8 million Americans received an additional dose. So we're not counting, those are ones we kept track of, and some of them may have received an additional dose, a third dose, even before we were able to monitor that. That is beyond, when you compare to Malawi, that is beyond the number who've actually received their first dose. I think we're still way under 500,000. So it's such a discrepancy between the two settings, and it's been very insightful, and at the same time very just heartbreaking to be in both worlds and see what is happening at the ground level. So I hope to share that perspective with you all, and hear your opinions as well. Thank you.
Thank you for sharing that amazing work, Tembi. I think it's very enlightening to see that there are people who are in the front line that are able to recognize these discrepancies. As you say, back in Malawi, you know, there's that challenge with the vaccination numbers, and you are in an environment where you're achieving the greater numbers and percentages in terms of the individuals that have managed to get their second doses. Just to move on a little bit, so at the start of the COVID-19 pandemic, the world seemed to agree to put up a united front in the fight against the pandemic. So promises were made, most notably through the creation of COVAX. So this is a global alliance formed to acquire COVID-19 vaccines from manufacturers and equitably distribute them. So these promises were broken by wealthier nations that decided to buy their own vaccines directly from manufacturers. This has caused significant disparities in the COVID-19 vaccine supply, with less than 2% of the African population currently vaccinated versus an over 50% in the US and 80% in Europe. So basically, I just want to find out, what are your thoughts about the COVID-19 vaccination status? In that, what are the underlying causes of vaccine inequity in supply of the COVID-19 vaccines? So this is open to any one of the panelists. You can just come in. Thank you.
Thank you, Mwelwa. If I may come in first. So my thoughts on the current COVID vaccination status. I think there is a striking divide, as you've stated, between the African nations and the high-income countries, where you see that the Africa continent is slowest in the COVID-19 vaccination. So some of the underlying causes are mainly due to the limited quantities, as Fred mentioned earlier. You find that our expected quantities, when you look at the vaccine deployment plan initially, what we anticipated to get through the COVAX in the first quarter, then by 2021 end, and then what we anticipate to get in 2022. You find that the doses have been fewer and they are limited. This is mainly because also the COVAX facility has not been able to access all the anticipated doses that they hoped to have obtained. So that's why even the countries, the doses are just trickling in. Then you also look at the pricing of the vaccines, the costs are quite high. So when we talk of the COVID-19 vaccine and you compare to our routine vaccines, the costs are really, really high. $7 per dose is quite high compared to the other routine antigens. Then you can also look at the scarce manufacturing. The manufacturing has been limited mainly to the high income countries. And when the COVAX facility opened up for countries, we opted for AstraZeneca, which was largely produced in India. And as Fred mentioned, when there was an upsurge in the COVID-19 cases in India, all our orders were put on hold. We waited for our shipment for over 2 months. We could not get them. So those are some of the underlying causes, and I would like to pass on to my colleagues to add on from there. Thank you.
Just to hold you, Jacqueline, while I still have you, thank you. I'm just wondering if you could just give us just a brief overview of your involvement in terms of the COVID-19 vaccine response so far, what your work has involved, basically.
My work has mainly spun around the vaccine and logistics pillar, where we are talking about the actual COVID vaccines and their accompanying equipment. So it spans from the planning to the distribution to the stock utilization to minimize wastage due to expiries. As you may notice, some countries are receiving doses that are about to expire. You have a shelf life of 2 months, and then you get into a crisis mode to make sure that you don't lose any dose because of expiry. So my work has really been largely in the supply chain piece. Thank you.
Thank you so much for that, Jacqueline. You can see the wide diversity. There's logistics, there's somebody who's in the front line. So that's really good to know. So I think I'll go over to Fred and Tembi. So we are back to our question on basically the vaccine status, what you feel or think are the underlying causes of vaccine inequity during this COVID-19 response.
All right, thank you, Mwelwa. So personally, the observation is that this COVID pandemic devastated the developed world much earlier than it did to the low and middle income countries. Coincidentally, it happened to be that this developed world is where most of these vaccines are being manufactured. Even the normal routine immunization vaccines that we've been using before, they're manufactured in these places. So these countries quickly enforced some restrictions, I think, on exports of these vaccines, as well as the respective technologies. You take an example of the AstraZeneca vaccine, which I think are around April was gazetted, I think, as the sole producer for the Oxford vaccine. That was April 2020. Soon thereafter, I think the US and Britain made an advance commitment of about 400 million doses. That was before the COVAX facility was formed. The COVAX facility was then only formed after a month later, I think towards the end of May 2020. And yeah, even though it had some sort of backing from WHO, from the Coalition for Epidemic Preparedness Innovations and Gavi, they didn't have enough resources to make advanced commitments like the developed world had done. So from the onset, this facility that had been established to ensure equitable distribution of vaccines was sort of fighting a losing battle. It started lagging behind. So you realize that the COVAX facility missed out on delivering vaccines at the same time as the developed world was starting to vaccinate. I think by about 2 months, because the first doses were delivered through the COVAX facility were around Feb to Ghana, and that was almost 2 to 3 months much later than the developed world had started vaccinating. So this has really curtailed progress in terms of uptake and coverage of vaccination in the developed world. For example, right now, by the end of 2021, the COVAX had committed or had planned to have distributed over 2 billion doses to LMICs. But as of date, I think they have just distributed over 210 million doses. That's just about 10% of the initial plans, and we are closing into the end of the year. So this has really been very, very problematic, and it has left most of the LMICs at the mercy of some of these developed countries that have actually stockpiled some of these vaccines to actually vaccinate the entire populations, not prioritizing the priority populations like science has told us to manage this pandemic. So most of these LMICs are relying on a few, of course, for doses that trickle in through the COVAX facility, but as well as some donations from these nations that have stockpiled. But like Jackie has mentioned, what is coming through has limited shelf life, and then it causes a panic in distribution and inoculation. Yeah, let me pause here.
I agree with what the other panelists have mentioned as causes, but I think that at the root cause of it, we need to look at the power imbalances that exist between high income and low income countries. We need to look at the political landscape and how a lot of how a lot of vaccine distributions or donations have actually circumvented COVAX and become bilateral agreements, right? Instead of per need. We also need to look at economic imbalance because these high income countries were also able to draw supplies from COVAX early on, which was controversial in itself. And some returned it and some still use it at the population. But at the end of the day, these different power imbalances, I think, are at the root of why there's such an inequity, or why the distribution is just unfair. the problem is none of this is transparent. So we don't know what formulas people use to allocate the vaccines in the beginning. We don't know which countries had abundance, which millions and millions of had an oversupply of vaccines available to them, and how many high-income countries have destroyed that they could have reallocated to lower-income countries. We know that manufacturing, part of it, it's not that there aren't other. I guess we can still use other facilities for vaccine manufacturing, but a lot of it is locked up with intellectual property or patents that it basically restrict who can produce. So there's so many ways of increasing supply and rectifying these problems, but just when we go back to the core of it, that the economics of it, the power imbalances and the politics of it, I think is hindering all these problems. This is not the first time we've experienced this. With the HIV pandemic, we had similar issues with drug distributions early on, and we also had similar dynamics with other high demand pharmaceutical products. I think that we, with the current supplies that we have now, we're capable of doing so much more. It's just how the allocation process, yes, we can't purchase them, yes, they're expensive, but based on research that I've read and articles and discussions I've had, that there are ways of making it cheaper, more widely available, ignored, and of countries have hoarded supplies, right? So more supplies than they need at the moment. So I think it's more, we need to start looking at the power, politics, and economics related to vaccines at the core of all these issues.
Thank you very much, Tembi, for that. Just had a follow-up question to our chat. Given the challenges that are currently being faced in terms of the vaccine supplies for the COVID-19 response, so we're looking at the high demand for vaccines, we're looking at the high cost of vaccine production, is it the scarce manufacturing capacity, and the poor global and continental allocation procedures for many African countries. What would you say could change for the better in terms of vaccine supply?
So some of the things that I think would change for the better in this case is to diversify our supply, our sources of the vaccines. For example, what Thembi mentioned, some of these, the manufacturing and the vaccines, it was limited to particular pharmaceutical companies. They were dominating the market, there was monopoly, but right now, we've learned from the AstraZeneca shipment, which was affected during the India upsurge of COVID-19 cases. Our governments have opened up to receive other options available in the market. So when China came and said, hey, we have Sinovac, we're so happy to receive. And even with the different country purchases being made, we've opened up to different types of vaccines so that we are better prepared in case of anything, we have a backup. Then something that could also be done is improving our health. This is probably long-term, but improving our health system. I think the pandemic got Africa when it was least prepared in terms of health system infrastructure. Way back 20 years ago, we talked of the Abuja Declaration to improve our health financing, our budgets. And when you look at the budgets for Uganda, it's even worse because we thought we had progressed to close to 8% of the GDP, but we are going back to 5%. According to the declaration, we all agreed as countries in Africa to increase our budget to 15%. So the pandemic got us at a point when we are not prepared with our infrastructures. We don't have the capacity in terms of human resource, in terms of the equipment. So I think moving forward for future, it would be good to kind of walk the talk. When we make these declarations, when we come up and say we need this budget, we never know when we shall need these systems in place. So if we had effected this budget, our systems would have been more prepared for the pandemic. Then also, talking of the commitments we make, when you look at the Addis Declaration on Immunization, when you look at right now, the African Union is trying to strategize for the next 50 years or so, preparing manufacturing capacity in Africa. So if this remain on paper, another pandemic will come in and we shall still not be prepared. So what can we do at this point to make sure that these beautiful and wonderfully stated plans are put in use? Thank you.
Yeah, maybe just some little addition to what Jackie has submitted there. I think also, I think the global community needs to look at addressing barriers to local production, because a few of these LMICs can put together capacity to manufacture vaccines, but the barriers around intellectual property rights, like Thembi mentioned. So these sort of limit production, or it's by design limiting production to just the developed world and not expanding it to geographies that are closer to the low and middle income countries, complicating distribution channels even further. Also, in addition, one other thing that I would like to mention here is the power to enforce some of these treaties by the global bodies that have been established. For example, WHO, Gavi, CHEPI. They need to exercise their powers to compel some of these developed countries to play by the rules. I understand, of course, most of their funding of these global bodies comes from these superpowers. But like Jackie has mentioned, if we put all these treaties and agreements on paper and we don't play by the rules, then it does not help the entire world. And a pandemic like COVID, you cannot limit solutions to just a certain geography, because it doesn't help. It will just keep coming back to you. Yeah.
I agree with what both of them said. I think that there are long-term issues that we need to address, and one which is very important, manufacturing capacity, and then there are short-term issues which we also need to address, right? Things that we can do now and things that we can do in the future to resolve supply side issues. And I think that in the short term, we, as whether it's, when I say we, I mean, whether it's as the African Union, whether it's as individual countries forming a collective, we really need to hold these international bodies accountable, because these are empty promises, unfulfilled, and we got the short end of the stick, and we continue to get the short end of the stick just because of these imbalances. But part of it is because we're typically on the receiving end, of the donor recipient dynamic. And please excuse my language, but beggars aren't choosers most of the times in these things. And I think it's something that we need to we have to change that position or change that dynamic. Otherwise, it's just going to repeat itself. And this is not the first time that this has happened. I'm glad COVAX was there and at least has alleviated some of the problems, because we've never had to distribute vaccines at this scale globally and this fast. So they did alleviate some problems, but the fact that we're still facing the same supply issues over and over. The fact that other nations can jump the line and get their vaccines before, the fact that the whole continent of Africa does not have a single manufacturing capacity, the fact that all these vaccines are not designed or with our setting in mind, right? Where we have remote areas that are hard to reach, that shelf, all those considerations, had they been, I think, production more locally would have been priority considerations and in the design. But since everything is it's a market, so they're gearing it towards the person who will pay the most amount of money and who will pay the fastest, right? Which is the high income countries. So I think once we shift that dynamic, things will change. We also need to hold our local leaders accountable. I think sometimes politicians are blind to, they're there for 4 or 5 years, they go, some of them have never experienced a pandemic in their, while they were in power. So their priorities are mismatched, right? That we need, yes, we have the budget declaration. Yes, we need to spend more on healthcare expenditure as a percentage of our budget. But if we have leaders who are, I guess, not very aware or of the impact healthcare has on development, of sustainability, of everything, then they won't hold other people accountable. They won't drive towards actually establishing manufacturing capacity in Africa. They won't gravitate towards having I guess bargaining or collectives that can bargain change our position basically with this international agreements. And they certainly won't put the high income countries we partner with to task. I should say these are my own personal opinions, and they're not a reflection of any of the organizations I'm affiliated with. So please keep that in mind as I respond. Yeah, thank you.
Okay, Cindy, thank you very much for everyone's responses. So I just want to have you share just very briefly what your thoughts are about this. So seeing that the WHO has recently reported that over 450,000 doses of the COVID-19 vaccines have expired since the COVID vaccinations were introduced. So mostly this has been attributed to delays in shipments as well as challenges in in-country distributions. So very briefly, I just wanted you to just share what are some of the challenges that you've experienced in the rollout of the vaccinations.
One challenge that we experienced at the rollout and during at the time when we were launching the vaccine, the vaccination was the myths and misconceptions. It was, they say it's not just the pandemic, but also the infodemics. There was a lot being said, non-factual, misleading information going all through the media. So it was one big challenge that hindered the initial uptake of the vaccine. As a country, our uptake improved when the second wave hit. That's when it was like a wake-up call for everyone looking for the vaccine wherever they were. And then we stocked out, there was no vaccine. We were waiting for 2 months for the next shipment. So that's something I want to throw in there for us to discuss more. But I welcome other comments too on some of the country specifics.
All right, let me just supplement a little. I think from the Ugandan perspective, we've really not had to destroy any vaccines as a result of maybe wastage and expiries, but observing what is happening from other LMICs, and I think some countries have openly discarded some of the vaccines received, and it's mainly because of the shelf life. I think Malawi, I think sometime in March, I think around March, they received vaccines whose expiry was 13th April. And so they could not that stayed were discarded, but mainly the challenge is short shelf lives. But also the other big challenge I think that happened to most of the LMICs, we started getting vaccines before countries properly earmarked resources for deployment. So those initial consignments that came in through the COVAX facility were not matched with on-ground resources for moving the vaccines quickly from the national medical stores to the vaccinating sites, training health workers, and also facilitating them to conduct this type of vaccination, which was actually targeting the platform, mainly the elderly, who have not been a target for the routine immunization platforms before. And then also, finally, also the hesitancy that has been mentioned. There were a lot of issues around hesitance, even among the priority groups, surprisingly also including the health workers that are supposed to build confidence and administer this vaccine to the population. Yeah, I'll leave it at that.
Okay, so given those responses, what do we think or feel should be done to mitigate some of these measures in order to improve the vaccine distribution in our communities and the communities that you serve?
So two different communities. Again, I'll start with within Washington, D.C. We're in a space where there's relative abundance of vaccines, right? So I'm not saying there's so much that everyone could get 4 shots, but relative to low-income countries. And yet, as of today, only 66% of fully of adults 12 and older who are eligible for vaccination have been vaccinated. So it's not a problem of supply, but it's a problem of meeting the communities where they're at. So addressing the hesitancy issues, but also addressing core distribution problems, that sometimes people aren't comfortable getting vaccines in healthcare facility settings. They're more comfortable getting them in their communities, right? With community leaders they trust, with people, with people they can see, they can relate to. So part of it is we're making a lot of efforts trying to shift to use models that we had in Africa of community care workers, of community strong healthcare systems. So that's one thing that needs to be addressed. In Malawi, I know that they did receive they destroyed, as you said, some vaccines in March, and part of it, yes, was the shelf life. But another aspect of it is, I think we need to be flexible with our priorities. Yes, healthcare workers and vulnerable populations should be first. But one thing that I did see, that a model that I learned about here, was anybody who's available gets the vaccines. Outside of, if we've tried to engage our target population and that has failed, right? And we still have extra doses. Anyone walking in the streets, around pharmacies, around market, was offered the extra vaccine dose, right? So in that sense, you don't waste, because yes, you have your priority groups, but you can go beyond or around that. Healthcare workers, yes, were hesitant to get the first dose, but once we opened it up to communities and people were able to see that you didn't grow like an extra arm, there were no side effects promised, then that radically improved. So I think that yes, there's a mismatch in resources, but we knew something was going to come. I think we could have planned better, and I think we should have used our existing knowledge from expanded immunization programs that we've been using for over 20 years to address the same distribution problems, or to address that. So I just think that we need to do a better job of implementation and using everything that we've learned from HIV, from other immunizations, to the same with COVID. And we really need to rely on our community systems. Yes, shelf life is a problem, but if you go outside of the priority areas and offer it in spaces where communities gather, then that sort of reduces the wastage. There's no reason for us to be tossing out vaccines, or if we think we're not going to use that supply, we should be able to shift it to other high demand areas. I know some countries have been able to trade vaccines with lower shelf lives, and then they will be returned. So vaccine sharing between countries, let's say where they're actively undersupplied, and then when the other country receives their supplies, they return it back to the country they borrowed from. So I just think we need innovative models and not stick necessarily to what we thought was the best practice. We need to adapt and innovate based on what we have. Thank you.
Okay, thank you very much for those responses. Very elaborate indeed. I just want to see if we have any questions from the audience here. Let me just have a look. Okay. Okay, so I'm seeing a question here that says, to what extent is there still significant public resistance or misconceptions about COVID vaccines in Uganda, Ghana, or Malawi?
Yeah, let me respond to that for Uganda's case. I think from observations, I think there is still hesitance in certain pockets, but like Jackie mentioned, because of the second wave that was so devastating that we've just gone through, and probably we're at the tail end of it, and hopefully we don't go into another wave. Because of that, the current demand for vaccination is still relatively high, but we will only be able to tell once we get a substantial number of doses into the country, which is expected this month, later this month and next month. But for now, most of them, regardless of short shelf life. But the issue of hesitance is still there. Those sentiments still come in, and also preferences of what type of vaccine to take. Yeah, but the rightful communication is being channeled.
Thank you very much for that, Fred. I just wanted to say before we close, I just wanted to share a lightning round of questions for all our panelists.
Just before you jump in, there's a question that came in earlier from Aston. He asked, can any of the panelists speak into the effect of diversifying sources of COVID-19 vaccines on vaccine deployment plans and people failing to get the second or third booster shot of a specific vaccine whose supply may have run out from the COVAX facility? Is there any data speaking about this vaccine interchangeability in case we experience a severe shortage of one vaccine while having plenty of another in a given country?
Yes, there was some studies early on mixing different vaccinations. One of the concerns was adverse events, which are just like side effects of mix and match, but those were relatively minimal compared to the benefit of having immunity to having some form of immunity to COVID. So it's an ongoing, there's a lot of ongoing studies, but even locally here, there've been, we've been mixing at times, not intentionally, because ideally you want to get the same series, right? But and in resource limited settings, you just have to do with what you get, which is not ideal, but the having COVID impact us, slowing everything, determining our future is worse than the adverse events that may come about from mixing different regimens.
Thank you. If I could speak to the first question that Anita said, it was the effect of diversifying the sources of COVID-19 to the vaccine deployment plans. As a country, I think if you look at our vaccine deployment plan, the initial one, we were hoping to get more of the AstraZeneca. We did not plan for any ultra cold chain requiring vaccine, the Pfizer. So our plan has greatly changed, because at the moment we are anticipating to get more than 3, actually 4 or 5 different vaccines, COVID-19 vaccines. So we've had to revise our plan and update, where we had not quantified the ultra cold chain equipment availability, the capacity. We've had to conduct assessments. We've had to update our plan to reflect what is happening at the moment. So I think these plans are living documents, and countries can always sit and revise and edit according to the current situation at hand. And yeah, that's what I can say.
Okay, thank you very much, Jacqueline. Thank you, Tembi, for sharing. Thank you, Fred. So as I was mentioning earlier, I just wanted to share a few, like a round of enlightening questions. So I just wanted to find out what are some lessons that can be learned from the COVID-19 supply chain and distribution, so for the vaccine specifically. So what can be done to prevent the recurrence of these inequities? So to ensure availability, accessibility, and affordability of quality vaccines, mainly for Africa and low-income countries in the future.
Yeah, all right, I'll quickly submit on this. I think, like we've initially mentioned, I think is the global agencies, WHO and Gavi and JP, to take initiative and execute their mandate in terms of making sure that research and development of vaccines does not have very stringent patents. Technology transfers are allowable, and intellectual property rights are managed in such a way that where there is an LMIC that has capacity to produce, that technology is extended to them. Then yeah, the second issue was around the intellectual property rights. But I quickly wanted to allay fears for the Ugandan question that is asking about missing out on your dose if there's no matching and mixing and the vaccines run out. The plan is in such a way that for doses that are very limited in supply, like Moderna and Pfizer, as they come in, distribution is done in such a way that reserves are made for the second dose of that batch that comes in. And the distribution is also done in groups, organized groups that can easily be accessed. For example, teachers and security people for some of those complex vaccines to administer.
I think that we need to infuse accountability and transparency into the whole supply chain in regards to vaccination. I think that going forward, I keep on, this like frustrates me, and that at the same time, I keep on trying to understand where in the global community, what's our limit for saying, technology sharing is for, you know, for the greater good. What's the limit? Because currently we're saying no, we can't. A lot of these big organizations are saying no. Sharing patents or opening them up will stifle innovation. But at the same time, I keep on questioning that. At what point do we say enough is enough? We need to do this because it is literally for the greater good of the planet, and vaccines benefit everybody. What's happening, we're such a global village that what's happening in the middle of nowhere, Malawi, would affect us here just because of how mobile our populations are, just because of how interconnected we are. So I think that we need to revise all of that. And we also just need to hold our leaders accountable as community members, right? We can only do so much sometimes with the bigger organizations, but locally, we also need to hold our leaders accountable and ensure that we have grassroots movements supporting all our actions, that we engage our community leaders as well, or our community members in this. And I think it will assist with everything from hesitancy, everything from our leaders reprioritizing healthcare, and in the future shifting towards local or supplies of vaccines being produced rather than or cooperatives of African countries producing their own countries rather than relying on purely on donations or sorry, I have a lot to say on this topic, so I'm just going to stop now.
Okay, that's all the time that we had today. I know we are a few minutes over, so apologies for that, but thank you all so much for joining us today. Thank you to our panelists, Thembi, Fred, and Jacqueline, for the wonderful informative discussions and for the enlightening thoughts that you shared. I want to say a huge thank you from GHC to our moderator, Mwelwa. And thank you very much for moderating today's session. We appreciate your time and your insights that you have shared with our attendees today. Thank you so much. For community members, just as a reminder, the community portal is available for you to continue these discussions, to continue sharing your insights, resources, and any questions. So use that as a resource. Thank you all. Have a good rest of your day. Bye.